morning, everybody. We're going to call to order the Pension and Health Benefits Committee. And the first order of business is roll call. Thank you.
Ramon Rubalcaba.
Present.
Kevin Palkey.
Good morning.
Deborah Gallegos from Malia Cohen.
Here.
David Miller.
Here.
Orena Ortega. Jose Luis Pacheco.
Present.
Teresa Taylor. Yvonne Walker.
Excused.
Melissa Willett.
Thank you, everybody. Now we're going to recess to go into closed session. I apologize, folks, but we will be back hopefully within 2 hours. Thank you, everybody. As agendized, yes. We're back in open session, and we will continue with the remainder of the open session agenda. Well, our next item is the executive report. Mr. Molds and Ms. Mo.
Good morning. Kim Long, CalPERS team member.
Now you're on. Now you're on. Done. Yes, that's good. Yeah.
Thank you, Magic. Good morning, CalPERS team member, or Kim Long, CalPERS team member. Wanted to share a few things with you today. First, our next CB will be held virtually on April 10th and 11th. We're also planning one for June 7th and 8th in San Luis Obispo at the Embassy Suites. It's now posted on our website, and registration will open in early May. Next, we're preparing to begin another benefit verification cycle. This is one step we can take prior to utilizing SoCure. This isn't a new process. We perform benefit verifications regularly. In fact, the last one was in 2022. Through this cycle, we are focusing on reducing risk to the fund and overpayments that result when members' deaths go unreported. The process includes sending a letter to the identified benefit recipient, requesting documentation to certify their eligibility to continue receiving benefits. At CalPERS, all CalPERS payees may be subject to receiving this letter at some point while receiving ongoing monthly benefit from us. But the upcoming cycle, we will reach out to approximately 8,000 retired members, or approximately 1% of our retiree population. We spent considerable time and thought determining the high-risk individuals in our system. Some of those include the last time they met with their healthcare provider, the last contact they had with CalPERS, if they live in a state that doesn't share death reporting, and the amount of the death benefit payment. Another factor is age. We have approximately 1,200 benefit recipients over 100 years old. And in fact, 102 benefit recipients that are over 104 years old. The kind of documentation that is required is a certification of eligibility for payment form that is notarized, a letter from the member or a letter from the member's physician on their letterhead stating the member is in their care, or a letter from the care facility that the member resides in on their facility letterhead stating that the member lives in their facility, or completion of this acknowledgement section of the certification form by a bank representative. And of course, if members have challenges providing proper documentation or they have questions, we'll work with them before any benefit payments are held. Members can contact our contact center or send secure messages for assistance. Before I move on, let me emphasize why this is so important. In the 16-month period when we utilized a death verification service, we received almost 26,000 reported deaths from that service. We knew about 15,000 of them, so we processed 11,000 of them that we were unaware of. The average monthly warrant for just those 11,000 was $2,173 per month, and that's just for the 11,000 population we were unaware of. This is a significant impact to the fund. Taking the average monthly warrant times the 11,000 people is over $23 million for the 16-month period, or almost $1.5 million per month of reduced overpayments. And this represents just 1 month of overpayment. In some instances, the death may go unreported but for multiple months. And again, as you're aware, it's very difficult to collect the money after it's been paid unless there's an ongoing payment to a beneficiary. I briefed the stakeholders this month on March 14th about these upcoming letters, and we'll start sending these letters after this March's meeting. Finally, in closing, as in typical fashion, I thought I would give you an update on the retiree warrant project. To date, almost 3,400 retirees have successfully used our IVR or phone system since it rolled out in October. And the online link that launched on January 20th, so about 2 months ago, has been successfully used almost 21,000 times. I know there's a lot of interest in the retiree warrant information, so I thought I'd just continue sharing their utilization. And that concludes my comments, and I can turn it over to Mr. Molds.
Thank you, Kim.
Great. Good morning, Mr. Chair, members of the committee. Don Molds, Chief Health Director. I have a few updates this morning. First, I want to share this that this year open enrollment will be held September 16th through October 11th These dates are consistent with prior years, and I like to announce them in March so that they can be added to calendars for planning. The preparation for open enrollment is already underway. Next, I'm pleased to share that CalPERS has received the Moonshot Award for our Biosimilars First Pharmacy program. The award is given annually by the Purchaser Business Group on Health to member organizations that are reimagining the status quo with innovations that improve healthcare quality, affordability, and equity. Dr. Logan's talked with you in the past about the Biosimilars First program. We launched it a couple of years back in our PPO basic plans, requiring the use of biosimilars for new prescriptions where biosimilars are available and clinically appropriate. The program includes all of the drugs that have an available biosimilar, and it has achieved widespread patient and clinical acceptance. Biosimilars play an important role towards working to lower healthcare costs while offering the same efficacy and safety as the original biologic drug. Next, I want to share that we held our first health policy roundtable earlier this month on the topic of specialty pharmacy. The roundtable featured presentations from 2 terrific outside experts and a really good discussion. I want to particularly thank Mr. Palkey and Ms. Walker for participating. It was helpful to have them there. Our team is crafting a summary of the notes on the roundtable that we'll share with the board and post on our website. We'll let you and the stakeholders know when they're available. Mentioning the roundtable discussion is timely because I want to share that we're preparing for a pharmacy benefit manager solicitation for later on this year. As you know, we currently contract with OptumRx for pharmacy services and for our PPO plans and the HMO plans outside of Kaiser Permanente and Blue Shield. You've heard me say before that we've negotiated best in market pricing with OptumRx through our acquisition price-based contract, but I think we all agree that we continue to spend too much on pharmaceuticals. My team looks forward to working with the board this year to secure the strongest contract possible. The new PBM contract would take effect January 1st, 2026. Last, I want to make an announcement that I'm very excited about in our long-term care program. Starting April 1st, we'll be launching our long-term care aging in place program, which invests in pre-claim interventions that help our policyholders stay in their homes longer. As we've talked about in the past, the vast majority of our policyholders want to remain in their homes as long as they can do so safely. This program will help them do that, and by avoiding costly institutionalization, it also saves precious premium dollars that are used to fund the program. Moving to our agenda today, we're continuing our health plan spotlight series with the leadership teams from Western Health Advantage and Sharp Health Plan, who are both joining us today. I know you're looking forward to another great discussion and the opportunities to learn more about these plans and how they are supporting our members and our strategic goals. So I'll stop there and happy to answer any questions.
Thank you, Mr. Don. Now we'll proceed to the action consent item. I do have public oral testimony requested. Margarita Brown, please. Do we have?
Is this the right box?
Yes, please. And 3C, sorry, yes.
Thank you. My name is Marguerite Brown, and I see under its delegations that this committee has responsibility to oversee the cost and quality of the long-term care program. Is this committee also responsible for assessing the availability of the fund and, if necessary, determining the need for long-term care rate increases, ensuring a fair distribution of increases across policyholder groups, and providing timely and transparent information to CalPERS members on these decisions? If yes, has the committee begun consideration of premium increases for later this year?
It's not our practice really to always respond to public comment, but I'm sure staff will be happy to talk to you afterwards.
Thank you.
So I'm assuming we can go forward with we need a motion to accept. Move to approve, second by Mr. Pacheco. Need roll call or just, some? All those in favor? Aye. So the motion passes. Thank you very much. Now we'll move to information consent items. We have one request to pull item 4C, health open enrollment results. And I see Rob's pulling up front. So should I start with my question or you present?
Please go ahead.
I noticed we had a lot of activity during open enrollment, and I would believe it's because we did communicate to our members because of the double-digit increase in some of the plans, particularly Kaiser, that there were other options, and we asked people to shop around. And we noticed that Kaiser actually had a net loss of over almost 22,000 members. Total loss was about 26,000. And so I do want to commend the staff for the communication and members for shopping around and making changes. And I know we have the health plan spotlight later today. Our first inaugural was Kaiser, and we definitely had a good discussion where we laid out our expectation that this double-digit increase is harmful to our members, harmful to the plan, and we were very hopeful that we work together to make sure that does not happen again. Rob, you have any comments on the open enrollment results?
So thank you for your interest in this item. So yes, what we did see from Kaiser was a large migration out of their program. It was about 3.5% overall when you combine basic and Medicare, but more specifically on the basic side is about 4% of their members left that plan. This was in line with what we anticipated the projected loss to be, and also in line with what Kaiser was anticipating also. I'd also like to highlight some of the gaining plans, because there was definitely those plans who are competitive out there that our members made the choice to move to. So the largest gaining plan was Blue Shield Access Plus. They gained about 20,000 lives, or 21%. Trio was next with gaining 10,000 lives, or 31%, so definitely making an increase there. Next was UHC Alliance. They gained about 4,500 members, or just about 6.5%. And then finally, UHC Harmony had the largest percentage increase. They gained about 2,200 members and just over 46% growth for them. Lastly, I'll also mention that Western Health Advantage also saw a significant increase of about 25%, or about 4,200 members. So what does show that members were paying attention even more this year, thanks to our efforts that we, the health team, and with your direction, sent out letters about the significant rate increases. So members definitely are using our tools and shopping around more than they have before.
Thank you, Rob. Appreciate it. Any more comments from the committee? I don't see any. So now we'll move into the action agenda item number 5, proposed amendment and to regulation, definition, and reporting of full-time employment. Ms. Kim All and Kelly Alcock.
Good morning, Kim Mom, CalPERS team member. We have one action item before you today. This is the proposed amendments to the definition and reporting of full-time equivalent, or FTE, school pay rates. This is just a clarification of current regulations. We spent time the last couple of months working with our school stakeholders on this clarification. In addition, we sent out a circular letter to our school employers on Friday, March 8th, that was reviewed by the stakeholders, sharing this information with the school employer community. Kelly Aoki, the Division Chief of Policy Research and Data Analytics, will be presenting this item. We also have Brad Hansen, who's acting Division Chief for Employer and Account Management Division, here in case you have some additional specific questions. So I will turn it over to Kelly.
Thank you, Kim. Good morning, Mr. Chair, members of the committee. Kelly Aoki, CalPERS team member. This agenda item is an action item requesting approval to amend California Code of Regulations, Section 574, to describe how a classified school member's full-time pay rate shall be reported to CalPERS, followed by submission of the final rulemaking package to the Office of Administrative Law upon conclusion of the 45-day public comment period, provided no public comments are received. This proposed amendment only applies to classified school members and school employers. In 2000, the legislature enacted Government Code Section 20636.1 to standardize full-time employment for classified school members as 40 hours per week. Prior to the statute, school employers had the discretion to establish how many hours were considered full-time employment for their classified school members, resulting in inconsistent retirement benefits among classified school members across school districts. In 2019, CalPERS promulgated California Code of Regulations, Section 574, to define full-time employment for purposes of determining CalPERS membership eligibility, reporting overtime positions, and determining compensation earnable and pensionable compensation. School employers are required to report full-time pay rates to CalPERS. A common payroll reporting error we see is some school employers report earnings as pay rate when earnings aren't based on a 40-hour work week. These non-compliant pay rates lead to inaccurate final compensation and service credit earned, which ultimately results in inaccurate retirement benefits. Please refer to the table on page 3 of the agenda item. In this example, there are 3 employees and they're all earning $5,000 per month. Only employee C's earnings and pay rate, full-time pay rate, should be the same at $5,000 per month because employee C is working full-time. Employee A and B's full-time equivalent pay rates are higher than the $5,000 earnings because their earnings aren't based on full-time employment. Consistent with current training and education we provide school employers and to ensure accurate payroll reporting, the proposed amendment describes how hourly, daily, and monthly full-time equivalent pay rates are determined when earnings aren't based on a 40-hour work week. To assist school employers with conducting these calculations, we have a full-time equivalent pay rate calculator available on our website that will provide the hourly, daily, and monthly full-time equivalent pay rates using the same methodology as the proposed amendment. Over the past few months, we have worked with members of our school stakeholder communities and have received support of this proposed amendment. Following approval of this agenda item, CalPERS will submit the proposed amendment to the Office of Administrative Law to initiate the 45-day public comment period. Following the conclusion of the public comment period, if there are no comments received, we will submit the final rulemaking package to the Office of Administrative Law. If comments are received, we will bring this proposed amendment back to this committee with the comments received, our responses to those comments, and any amendments deemed necessary in the fall for final approval. Due to the regulatory process, the earliest this proposed amendment is expected to be effective would be January 2025, but it's more realistic that it'll be April or July of 2025. We understand that some employers may need time to update their payroll system and MOUs. We provided guidance in the circular letter that was issued on March 8th, and we encourage school employers to reach out to us now and begin making those changes. This concludes my presentation, and I can answer any questions you may have. Thank you.
Thank you. Does the committee have any questions? Mr. Palki.
Thank you, Chair. Thank you. You know, I've received numerous phone calls expressing their frustration on their numbers not matching up. And I've read through this multiple times, talked to contingency groups to hear, and obviously thank you for reaching out to those employers as well too. But I think the more that we can do to create that that clarity, and so that when they log into their MyCalPERS, the numbers match up and they can truly see what their retirement looks like is really beneficial to the school employees. So thank you for that.
Thank you. Any more questions for the committee? Mr. Pacheco, hold on, please.
Yes, thank you. First of all, I want to say thank you for the presentation on this important topic. As a classified school employee, I do appreciate this. This is very, very important. I'd like to know how would you be able to, with respect to the circular letter, this upcoming education forum, will there be any workshops for the folks there as well?
Thank you for that question, and that is something that we'll be making sure is added to the Employer Education Forum this year, is to provide education to the employers on the calculation and determine those full-time equivalent pay rates.
So education on the new calculator as well and so forth?
Yes.
Oh, excellent then. Thank you very much. Those were my questions.
Thank you.
Thank you. Now I think that's it. Thank you for your presentation. I need now a motion to, Mr. Pacheco makes a motion, second by Mr. Paki. Any discussion? I see none, so we'll call for the vote. All those in favor? Aye. Aye. The motion passes. Thank you. And now we'll move on, proceed to the next agenda item, which is information agenda items. And there's a what's that? Oh, I'm sorry. Thank you. Okay, so we had the ayes. Any opposed? Any abstains? Thank you, Madam President. So now, the item has been disposed of, adopted, and staff has work to do on that one. And now we'll move to information agenda item number 6A, retiree cost of living adjustment. Ms. Small.
Thank you. The next agenda item is an information item. The cost of living adjustment, or COLA, agenda item will be presented by Kimberly Polito, Division Chief of our Retirement Benefit Services Division, and I'll turn it over to her.
Thank you, Kim. Good morning, Mr. Chair and members of the committee. Kimberly Polito, CalPERS team member. Agenda item 6A is a fan favorite. It's an information item on the retiree cost of living adjustments, or COLA. As background, our retirement law provides for the payment of an annual COLA each May to all eligible retirees based on the rate of inflation as measured by the Consumer Price Index for all urban consumers, or the CPI-U. For year 2023, the rate of inflation was 4.12%, and this figure is what was used to compute the annual COLA this year. All retirees become eligible for COLA in the second calendar year of retirement. So therefore, members that retired in 2022 are eligible, or prior are eligible, for a COLA this year. COLA adjustments will appear on the May 1st retirement checks. In addition, there are instances where COLAs do not adequately keep up with inflation over time. We generally experience this with our retirees that have been retired for 35 plus years. The Purchasing Power Protection Allowance, or PPPA, works in conjunction with COLA to ensure that our members retain a purchasing power in alignment with what their employer contracted. This year, about 18,000 retirees will receive a PPPA benefit in addition to their COLA. The PPPA adjustment is also payable on the May 1st warrant. To illustrate the impacts to the COLA and PPPA this year, we've included in the agenda item chart showing the allowance increases by each retirement year. The majority of our retirees, nearly 96%, or over 750,000, are contracted for a 2% COLA. A little over 33,000 of our retirees do have a 3%, 4%, or 5% COLA provision, depending on what their employer contracted. In the chart in the agenda item, or up on the screen, you'll notice that retirees with a 2% contracted COLA will receive between 2% and 4.12% this year, depending on what year they retired. And let me explain further. The COLA for each retirement year is calculated based on the lesser of either the compounded COLA or compounded CPI-U, or inflation, since their year of retirement. So in years where inflation exceeds the contracted COLA provision, retirees are capped at the contracted COLA amount, and any excess is applied in future years. I think we've explained this as banking in the past. The banked amount can be paid out in years where compounded inflation is more than the compounded COLA. And you'll see an example in the chart under the retirement year 2008, Retirees in this group will receive 2.0% increase instead of just the 2% to finish catching them up this year. We do get questions from retirees why they don't get the CPIU, so I thought I would add a little extra context there. And since this is a fan favorite, we do have a lot of retirees looking for information, and we do a lot of communication. So our best way to communicate through these channels, we'll have an article in our spring newsletter, updates on our COLA website, and then also in various social media platforms. And then also retirees can log into their MSS account and see that May 1st warrant, and they'll be able to see the increase there. That's my little plug to hopefully encourage people to sign up for MSS if they haven't already. This concludes my presentation, and I'm happy to take any questions.
What did they do? Nobody. I don't have anybody that use. So there's no questions then from the committee, so thank you very much. So now we'll move into our information agenda items. 6B, which is our guest speakers from Western Health Advantage and Sharp Health Plan.
Ready to go?
Yes, please.
Great. So, Mr. Chair, this is the second of our health plan spotlight items and the second and third plans that we're spotlighting. As a reminder, we are taking a pause on these until you approve rates in July, but the series will pick up again then. Western Health Advantage is a low-cost HMO serving Northern California, based here in Sacramento. Representing WA are its president and CEO, Gary Mizell, and its chief medical and operating officer, Karam Arif. Western Health Advantage has been a great partner in our efforts to bring low-cost HMO options to members living in counties where historically access has been limited to the PPO. Sharp is a fully integrated health plan serving San Diego County. Representing Sharp Health Plan are President and CEO Melissa Hayden Cook, Chief Business Officer Michael Bird, and Chief Medical Officer Carrie Shames. Sharp delivers exceptionally high quality care while maintaining extremely competitive premiums. We only wish they were available in more counties than just San Diego. We're going to start with Western Health Advantage. So Gary, why don't I go ahead and turn it over to you, and
Great.
Welcome.
And good morning, everybody. I'm very pleased to be here today. Dr. RF is to my right, and it's nice that we can spend a few minutes with you today talking about one of our favorite subjects, which is Western Health Advantage. I'm going to take just a few minutes of your time and talk about some of the fundamentals of Western Health that make us who we are, and then Dr. RF is going to take the bulk of the time to talk about our clinical initiatives, which fall directly in line with and help support CalPERS strategies. So, first of all, the beginning. Western Health was launched in 1997, so we are the youngest of the plans, CalPERS benefit plan partners. Sharp is not much older than us, but we've been in business 27 years. I was the first employee of WHA. I went to work for the company before we had our Knox-Keene license, so I've been there 28 years. I was much younger. I had a lot more hair, and it was certainly a lot browner than it is today. So it's been an incredible, wonderful 27 years. Western Health is a 501c4 organized organization. Can we flip to the next slide, please? And then we're just going to freeze it there for a while. Our two nonprofit healthcare sponsors are Common Spirit, better known here in California as Dignity Health, and North Bay Healthcare, which is the healthcare system which operates predominantly in Solano County. Initially, we launched in 3 counties way back in 1997. We now operate in 10 counties 27 years later. I'm going to say a little bit about our expansion further in a moment. From day one, we have always operated as a fully capitated, fully delegated health plan. And when you flip back to 1997, that was an anomaly. Folks thought that we were crazy for starting Western Health Advantage in 1997 in a health plan field that was crowded. All the health plans that are here today were in existence, plus there's a number of them I could rattle off that have long since gone out of business. We knew we had to do things differently, and that's where the capitated delegated model comes in. So, and delegation's important because our health plan partners, on the professional side, our medical groups, and on the hospital side, our hospitals, conduct all first-level medical decisions, any authorizations or medical reviews. Western Health does not insert itself into that first-line medical care, and that's one of the beauties of our model. We remove the plan from that. And we all know that when you go to see your physician and he says you need an MRI, generally for most health plans, that's got to go to the health plan for authorization. That is not the way it works at Western Health Advantage. The medical group in which your primary care physician operates makes those decisions. So the goal from the start was to remove the health plan from as much as possible from the relationship between the patient and their physician, to get them out of that. So just to be clear, though, we do not delegate quality improvement. We do not delegate final appeals or grievances. That remains at the health plan level. That is very important. We are always there for our members in the end to make things right. We're licensed as an HMO. We don't always behave like an HMO. And I'll give you one example. Our Advantage Referral Program, which has been in existence since the very beginning. Normally, if you have a primary care doctor in an HMO model, your care has to be rendered within that primary care doctor's medical group, unless they can't provide that care. That's not the way we operate. If your primary care doctor, for example, says that you need to see a cardiologist, certainly you can stay within your primary care doctor's medical group, but you have the right as a member to refer yourself to any cardiologist in the Western Health Advantage network. Very different. We call it breaking down the walls between our medical groups, or a medical group without walls, and we're very proud about that. A couple financial facts you can see up on the screen there. Our medical cost target is 90.25%. Our administrative cost target is a little over 9%. Let me say something about the word cost, by the way. We do not use the word loss ratio. A lot of times you'll see that expressed as a medical loss ratio. We prefer to call it a cost ratio or a care ratio. I've always found it interesting that health plans are in the business of providing care to members. And then when they spend money to do that, a lot of our competitors say that's a loss. I've never quite understood that, because we are here to take care of our members. Certainly it's a cost, just like our salaries are a cost, our lease expense is a cost, but it's certainly not a loss to the organization. So we do not like to use the term MLR. When you add those two together, you can see that that nearly is 100%. So we purposely operate the plan at a very low margin. Our profit margin generally bounces around 0.5% or less. And we do that not because we're poor managers of care, but that 90.25% medical cost target is contractually set with our providers. So that's the target. I have been accused in the past of being a very bad HMO president, because why is your cost target so high? You guys must not know how to manage care. The answer is no. We are not here to make money at the plan level. We are here to return as much of the premium dollar as possible to the providers of care, to keep our admin low and our profit margins skinny. That translates into our ability to being one of your most affordable health plans. I think in our region, we are the most affordable health plan. That's all set by plan. That's not because we're poor managers of care. That's the way we do business. So before I hand it over to Dr. RF, I'll say we're very pleased to be a CalPERS partner. We were excited by growing over 4,000 lives this last open enrollment. Remember, we are only licensed in 10 counties, so we're not a statewide plan. So we were pleased by that amount of growth. We're now at a little over 21,000 lives with CalPERS. We want to continue to grow in the future, and we hope we do. One last comment back to our growth from 3 counties to 10 counties. We are interested in expansion, but we will only look at areas where our proposed provider partners can manage capitation and can do a good job of accepting delegation. That is the model, and it's been the model since 1997. So we will not expand into a county unless the providers are able to manage capitation and can do that first line delegated activity, because that's our method of operation, because that structure brings a relatively high level of satisfaction to our members rather than a fee-for-service environment. So with that, I'm going to hand it over to Dr. RF, who's going to talk more about our clinical initiatives which support the CalPERS strategic plan.
Good morning, distinguished members of the board. It's a pleasure to be here today. The way we've set out the next few slides is basically to talk about CalPERS strategic initiatives and how Western Health Advantage supports those initiatives. So I think if you go to the next slide, you'll see that, what's top of mind for our providers, for ourselves as a plan, and I'm sure for our CalPERS members, is access, being able to get in to see a doctor when you need to see a doctor. We know that the shortage in primary care is a national shortage, and there are not enough people in the world to sort of recruit your way out of that shortage issue. In that environment, how does one then keep access open and think of new ways of improving access? This is the strength of Western Health Advantage, is working with our providers. Because we are a provider-sponsored plan, we are very closely integrated with our providers. We have led the charge working with the providers in terms of redesigning the way simple things like appointment availability and the way the schedules work, and when somebody calls that front desk at the office, how do they get to the right level of care without having to necessarily see the physician every time? Can certain kinds of care be provided asynchronously? Is the way that we operated 10, 15 years ago in the medical office, is that really relevant today? And how can we think outside the box? And so we have the privilege of working closely with the various medical boards of our medical partners, being involved in helping them with practice redesign and looking at their ideas and refining them by balancing them against the needs of our members. So access redesign, as you know, is imperative, and the solutions have to be creative. And access is not just getting care by going into the doctor's office. I mean, so many of us, I think, learned during the pandemic how strong we are and how folks can become self-sufficient if they have the right tools. And so that's where the fact that we were lucky enough to have a significant change in culture, it was a survival matter, but it also helped us change the culture of care delivery. And so patients realized that they could actually take care of themselves if they had the right tools. And physicians realized that you could provide a lot of care through the virtual medium. And so that has become part and parcel of our access, is making sure that our members and our providers are able to match each other both in the virtual space as well as in person. On the health plan side, what we can do to support this work is bring in more and more electronic, smart, remote type of tools that members can use and get rid of some of those barriers to access. We know that financial barriers are big, co-pays are big, getting the prior authorization, referrals from the doctor, all of these are various barriers to access. So besides constantly working with our providers to help them with supporting their recruitment efforts and pointing them to areas where there may be a shortage in the network and, where there's a need, we've also done things on the plan side, such as introduce various kinds of programs, and I'll get through to them in the next few slides. And then, really empowering the patient, creating a lot of awareness with the patient, with the member, about how much ability they have to drive their own care by making tools that are available. For example, if your member can look at their blood glucose levels in the morning and correlate that with what they ate last night, and put all of that in the, and have all of that presented to them in the form of a simple application that presents all that information smartly, and then give pointers and advice on what to do now that your blood sugar is so high in the morning. Perhaps drink a glass of water because you're obviously pretty hemoconcentrated in the morning. So those types of simple things is how we can get members care that they need without leaving the member dependent on always having to get in to see the doctor's office to answer these kinds of simple self-care tools and techniques. On to the next slide. So we talked about access a little bit, and I'm going to draw a line between access and quality. We know that if a member is not able to get to care when they need to get to care, when they need that care, the quality of their health is going to suffer. That member may end up in the emergency room or seeking care, too late to be able to change the course of where their disease is bringing them. And so one of the things that we've worked hard on the last several years now is really shining a light on the blind spots. Those members who are not coming into care, we need to be aware of who they are and what their care issues are or what their care gaps are, and be able to get to those members to let them know, you haven't had your blood pressure checked now. We know that you have high blood pressure. Here is a tool to help you start checking blood pressures by, you can get a monitor at home. You don't need a copay for it. You don't need a physician's authorization. And by the way, this tool can record all your blood pressure logs. So when you go in to see a doctor, every 2-3 months, you've got a nice record there. That's an example of the kind of tools that we've made available to our members, removing barriers around copay and prior authorizations, so that they can take care of themselves, and then also help the physician take care of them in that quality time that they'll get with their doctor. We've also made incentives available to members to close their care gaps. So for our CalPERS members, for the last year now in 2023, we launched care gap incentives across a broad range of healthcare metrics, whether it's checking your blood pressure, getting your blood glucose under control, completing childhood vaccinations. We pay an incentive for every single immunization visit that a member has. This is important, right? We realize that with the pandemic, people really took a step back in terms of their trust in vaccinations. And unfortunately, as a result of that, there is a national issue with childhood vaccination rates. So what can the plan do? The plan can kind of encourage members by providing incentives and reaching out to the members in a personalized, targeted fashion when we know that they may be missing a care gap. The value of technology and science is that you can really help to create avenues for members to get care using intelligent predictive tools. What we now know as AI has been very well known to the medical industry. We used to call it predictive analytics. Now it's called artificial intelligence. It sounds a lot more interesting with that terminology, but you can predict who the members are, whose care may be suffering or may start to suffer, and reach out to them through tools that intelligently present to the member their various options and enable them to see themselves based on how their health is doing and their various parameters are, how they can make minor doable changes to their day-to-day life to help improve their care. And so we have programs for helping reversing type 2 diabetes. You never thought that, when I first heard about the fact that there was something out there that could reverse type 2 diabetes, I thought this is malarkey, this cannot be real. But in fact, you can help members get on specific diets, reduce their carbohydrate levels, and drop their blood glucose, and in fact, start to de-prescribe some of their diabetes medications. We have Maven Maternity available, which helps members who are going through pregnancy or have recently had a child, and their spouses get care. And you'll know recently with all the focus on doulas, through Maven Maternity, we're able to provide virtual doula services. We've had this in place with our CalPERS members during 2023. Blood pressure I mentioned. Simple things like, you've got back pain or you've got neck pain and you need to see a physical therapist. The issue used to be having to go in to see the physical therapist, taking time off from work and doing all of those things. And just talking back about access, if you can provide physical therapy to a member at home using the technology in their phone to monitor their exercise and give them some feedback, we've seen some great improvements over just 3 months of physical therapy at home, and we use this as an interchangeable with in-person versus virtual physical therapy. So those kinds of innovations, these are the strengths that the plan can provide. Our medical groups and our providers and our hospitals are focused on providing that care when the member's in front of them, and the plan can do its job by providing tools to our providers and to our members with respect to all the various disease management support that's needed, and be able to kind of make that available in a ready and easy fashion to access. On the next slide, we'll talk about equity. So equity, again, the pandemic, and a lot of events that happened during the pandemic really shone a spotlight on equity, and we all became aware that different folks of different ethnic backgrounds, different cultural backgrounds experience care differently. And trying to remove those disparities in care is what we view as equity in care. So in 2022, we achieved the national, medical healthcare distinction from the NCQA for cultural awareness and training, as well as we now have our members can look on our provider directory and evaluate their physicians, race, ethnicity, language, background to see if there's a good cultural fit between them and their doctor. We have all of our medical programs are available in Spanish. In fact, as we began talking about equity and hearing about equity, we led the charge, at least with our own vendors, and we asked them that if they wanted to be at the table with us, working with our members, they had to at least have their programs all available in Spanish. This year, we've done outreach for Hispanic members for the flu shot. We just wound up that campaign this last winter. We send lists every month to our providers on patients who are Hispanic, who have uncontrolled diabetes, so that we can focus on providing care team members who speak their language, being available to those diabetic members. And every month we send out a social determinants of health report to each of our medical groups, which identifies members who are having risk factors around housing insecurity, transportation issues, food insecurity. And we ask our medical groups, care coordinators, to reach out to these members and enroll them within their care management programs, because we feel that there's a social determinant of health issue here, that care management can help the members, get those resources that they need. Finally, I believe the next slide is going to be talking about just the alignment, of our mission and vision of our organizations. We are as Gary was talking about our beginnings, we are very, very close to the practice of medicine and working with our providers and that experience that they have. And so we firmly believe that our job is to be available in the background as support so that members can get the care that they need from their providers, and providers can get the tools that they need from their plan to help take care of those members. And we are grateful to be here with you today. Thank you.
Thank you. Don, do you want to? Okay. I was going to ask if we take questions now.
Why don't you go ahead with questions for Western Health Advantage before we move to Sharp?
President Taylor, please.
Thank you. Thank you very much for your presentation. I remember when I've been with the state since '94, so I remember when you came into us and then went away for a while for whatever reason. I don't know. But so I had a couple of questions. You have two medical groups that you're working with here in Sacramento, and I forgot what I heard in the beginning, and I forgot what they were. I'm sorry.
We have three medical groups. Mercy Medical Group here in Sacramento proper, Hill Physicians, which is the Independent Physician Association down here, as well as Woodland Clinic out in Yolo County, Davis area.
I'm sorry, say that again.
Woodland Clinic out in the Yolo County, Davis area, sort of greater Sacramento area.
Okay, so Hill Physicians is out of Dignity, so you're with Dignity Health?
Hill Physicians is affiliated with Dignity as a practice partner. They are their own independent physician association, and yes, we partner with Hill Physicians as one of our groups.
Okay, and then your provider, your hospital providers are Dignity and...
Correct. Here in Sacramento, it's Dignity, and then we have in the other counties we've got North Bay Healthcare out in Solano, and then Providence up closer to the coast.
Okay, that's what I was trying. That's what I was trying to figure out. Then my last question. I'm just amazed at what you're doing, which is unusual, to say the least. What by removing yourselves from the first line. So, what made you start this, and when did you start it?
That was one of our differences from the very beginning, because back in 1997. I don't believe in our market there was any other health plan that operated that way. And as I said, we knew we had to do it differently. It made no sense to bring another vanilla health plan into the Sacramento region back in 1997. It was a very, very crowded field. And I must say to your question, we were in CalPERS many, many moons ago. When we joined the program, I think there were 12 or 13 plans. Then there were 10. Then there were 9. Then there were 8. And then there were 3. Kaiser, Blue Shield, and Western Health Advantage.
I think I was on the board when that happened.
And we, let's just say that it was not our idea, but it was, at the time, the CalPERS plan was different. And it didn't appear that there was room in the program at that time with your strategy at that time for a regional health plan. But we're back. Stronger than ever.
Yes, you are. So, so that's good. I mean, I don't remember that, but and again, I wasn't here.
It's a long time ago.
Yeah. So I think also I had a question on, I guess it was the second to last slide, Maven Maternity. What is that?
So basically, Maven Maternity is a application. It's a program. It's run by a company that we worked with now for several years, and it provides virtual services to members who are either going through pregnancy, have just completed their pregnancy, may unfortunately have had a loss during the pregnancy, or as well as their family members. And it provides services from as simple as lactation consultants, doulas. OBGYN services, if a member wants potentially some additional opinions outside of the care that they're getting. This is an example of a program that members can actually drive it themselves. No copays, no referrals needed, etc. And just to go back to your previous question you had asked is, why do we sort of let a lot of those decisions happen at the medical group level? It's all baked in our history. Being a provider-sponsored plan, we very much understand the angst that providers deal with. And as a former practicing pediatrician, I dealt with as well, trying to get approvals for every single thing that you need. And to allow and to facilitate that initial level of decision-making to happen at the medical group makes a lot of sense. It sort of removes that additional barrier to care that can potentially exist.
Okay. That's what I missed. I didn't realize you were provider sponsored. So the providers that put this together, you haven't been able to get other providers to buy into the delegation and the other thing. Hold on. It's in my notes here.
So we've expanded into counties where we do find willing provider partners and hospitals who are comfortable operating in the capitated environment, taking that initial level of responsibility around, delegation of care and appeals. And so that's where we sort of limit our geography very carefully, and we grow very carefully.
Okay, I see. So you're very careful on who you actually go out to. So you're not looking to get just more.
No, we're not looking to grow just for growth's sake. And so we actually, as Dr. Arif mentioned, in Napa and Sonoma counties, we work with Providence Health. In Marin County with Marin Health. So while they are not sponsors or owners of Western Health. They are part of our provider family. And again, they accept capitation, and they are fully delegated for the care that our members receive in those counties.
And I just think it's a great idea, right? I think we all have that issue where, oh, I still have to wait for my authorization for my x-ray, or even, I think even blood work. I'm not sure, but yeah, so I appreciate that. Thank you very much.
Thank you, President Taylor. Next, we have Jose Luis Pacheco, trustee.
Yes, thank you. Thank you very much. First of all, thank you for your presentation. I found this really enlightening and so forth. My question is with respect to the equity part, and under the all the medical programs are available in Spanish. First of all, I'd like to know when that started, and has it been more, have you been, how do you do the outreach to the Latino community and so forth? You can elaborate more on that.
Absolutely, Mr. Pacheco. Thank you for that question. So the outreach to the Latino community, you know, it's always about how can you position the message so it's culturally heard. And so as an example, just recently in this last winter, we worked with the National Hispanic Medical Association to design small, you know, comic strips and storytelling sort of approach in Spanish to our Latino community around messaging around the flu shot. Your question, your prior question was also about how long have you been doing it for? Honestly, it was during the pandemic that we realized that there's a gap. You know, there's real inequity, and so at that point, as we brought on new disease management programs, all of these programs that we listed, as well as legacy programs that we had in place, we began to have some really robust conversations with our vendors. On here is we, the client, as the health plan, representing our clients, the members, need care in a language other than English. And we need this done in so-and-so time period, and we basically were able to, we found really willing partners, by the way. I think that the environment was such that everybody realized their eyes had opened to inequities in care. And so we've been doing this now for about 3 years. We also provide Spanish language translation for various materials, as well as, you know, on our website. And that work is not done. There's a lot that needs to be done, and so we remain acutely aware of how much more needs to happen.
Well, this is that's wonderful news to hear that. Although it's very young, have you seen any improvements in quality of care and so forth with respect to this new modality?
What we're finding that in our Hispanic population, where diabetes was relatively poorly controlled compared to our Caucasian population of members, we're seeing changes, improvements in the level of engagement. We are also realizing that as we speak with our providers, they've got a lot of learning and awareness building that has actually now happened in the last 3 years, and so it's a lot easier now to have the conversation around equity than it was back in, you know, early 2020, for example.
Fantastic. Thank you very much for your comments.
Thank you.
Thank you, Trustee Pacheco. And thank you for the presentation. I do want to commend you on your NCQA designation for the multicultural healthcare. And I want to thank you for expanding to Humboldt County. And we have seen that you have grown significantly recently. And you introduced a new a Medicare product, MyCare Select Medicare Advantage. And so it's growing, but we definitely I'd like to know what efforts are you making to expand it, because it's a very high ranked and also very affordable. So what can we learn from you today about your efforts?
So we've been in Medicare, our first year in the non-employer-based Medicare was 2021. So we launched our Medicare product right smack dab in the middle of the pandemic. Wasn't a great time to launch it. So we now have overall, we have about, after this AEP that happened this last fall, have about 4,300 Medicare lives. And we are slowly growing. Medicare, just like commercial, is a highly penetrated market. There are a lot of Medicare plans. We came to market with a zero premium plan, thinking we were going to be in our service area on the commercial side. One of the only no monthly premium plans, and the same year we launched, 2 others launched with zero premium. So it's a very competitive market. So we are growing slowly. We wish we were growing faster. We're looking at new ways to outreach to that section of the marketplace, and we hope to be a long-term Medicare Advantage provider.
Well, thank you very much. It's been very learning experience for us, and thank you for being part of the CalPERS menu. I think that concludes the committee questions, so now we're ready for Sharp. Don, if you want to introduce.
Melissa, I'm going to turn it over to you. Thank our guests from Western Health Advantage. You can do it.
Oh, all right. Good morning. Thank you for having us. It's a real pleasure to be here to come to talk to you about Sharp and Sharp Health Plan and what we've accomplished. And I'm really hoping that this time we have together, you're going to get a chance to really understand the character of our organization and the accomplishments that our people actually have achieved. Sharp Health Plan is a nonprofit, a 501c4. And our health plan has been around for 32 years, so we're 5 years older, I think, than WHA. But we've had the distinct privilege of serving the CalPERS members for about 10 years now. And as a nonprofit, we do not have stockholders, we have stakeholders, right? And for us, that's the greater San Diego community. And Sharp Health Plan is wholly owned by Sharp Healthcare. And Sharp Healthcare is the largest healthcare provider in San Diego, touching in excess of 1 million lives a year with thousands of physicians and volunteers, and through great compassion and caring that comes from the Sharp experience culture with Sharp. And I would say as a nonprofit, any margin that we do make goes right back into the community. And of course stays in San Diego and in California. Much like WHA, our medical cost target is right around 90, and we keep our admin expenses slightly below that. We target about a 1% margin because, when you're pricing business, you can't be sure, how that business will perform, but a very modest margin. For us. At the foundation, if we go to the next slide, please. At the foundation of Sharp is our mission, and our mission is to improve the health of those we serve with excellence in all that we do. We take it very seriously. This mission has been around for decades. It is shared throughout the entire organization. And particularly, our mission has us, setting standards in the community for quality and service. And you'll also notice that cost effective is in the mission, and it's been in there again for decades. Affordability for us is critical. You need affordability in order to create access in the community. I would say that there's a tremendous parallel in what you're trying to accomplish here with your strategic priorities, including affordability and quality access and the member experience. So it makes us very good partners. We deliver on this mission through our vision, and our vision is to be the best place to work, practice medicine, and receive care. And it does say up there, ultimately, the best healthcare system in the universe. People do chuckle about that. They want to know if we benchmark against Pluto. Why did we pick universe? And we picked the word universe very deliberately because for us, this is a journey that never ends. It's a journey of improvement and a journey of progress in transforming healthcare. So we work through our mission, our vision, through a foundation of our culture. And we have actually a nationally recognized culture in the Sharp experience. And that culture is really to transform healthcare every touch, every time. And we all take that very seriously. You'll see there's a flame there, and it's purposeful because the flame represents the spark that's in all of us to make a difference in our role in the Sharp experience. And people have tried to duplicate it, and it's not one thing, it's everything. And it's really that culture seeking to transform healthcare, that journey that started 20 years ago for the Sharp experience, that really binds us together as a delivery system. It's that culture and promise to have a top decile performance in our 7 pillars of excellence. quality, safety, service, people, finance, growth, and community. I mean, you can't touch a sharp health plan person or even a sharp delivery system person that doesn't know that commitment to the sharp experience, the responsibility that requires of all of us to make a difference in our community, the community that we live and work in. It's very, very profound. Sharp is actually an icon, if you will. It's a community asset. About $570 million a year goes to support the community. It is about $1.5 million a day that goes to the community. So we're really part of the safety net. We're part of the very fabric of the community. And I like to say Sharp's the largest donor to San Diego, if you will. And we wear that as a badge of honor. And this commitment, this deep commitment to the community was no more evident than during the pandemic. And it wasn't that long ago. The Sharp Health Plan, our medical groups, our hospitals, our volunteers and our physicians all came together. And what we did was really extraordinary. And before we were ever asked, we eliminated copays and related to COVID and co-insurance and created enormous infrastructures for drive-by testing and worked directly, our Sharp Healthcare team worked directly with the county. It was an amazing, amazing experience and really culminated in Sharp taking the lead in the vaccination in San Diego County, in our underserved areas, in our South Bay, being there early, bringing our Sharp experience culture to the vaccination site so that our communities were comfortable and could have access to this care. And I tell you this because I think it's our core differentiator. We've accomplished a lot. We're going to talk about that in a minute, but it's that underlying culture, that underlying commitment that keeps driving us every day, and a huge differentiation in the insurance industry. The health plan, Sharp Health Plan, has a very diverse network of providers. That's very purposeful. We have a multi-specialty, very large multi-specialty medical group with 20 locations. We have a very large multi-specialty IPA. We have community physicians, and we also have community clinics. And we do this very purposefully because we want to meet our community members where they are. And we have this Sharp experience throughout all of our network. We are provider sponsored. That's where this unification comes from, the sharing of the culture. And everything we do, our innovations and our improvements, they're all grounded in the Sharp experience. As a health plan, I know our team is just very proud to be the best representation of this amazing delivery system, really the best expression of managed care, the incredible results that come from that and discipline that comes from that. So, and you're going to be seeing some of those results in just a minute as we go through this. We're very tightly knit together, and in doing so, and we're very committed to the care model as well as the service model. We're able to, and we're an improvement company, always improving. And so we find breaks early, we fix them, and we systematically fix them so that we can have really the best experience possible. And our results and our member satisfaction really speak that organizational-wide commitment. If you go to the next slide. All right. Well, this is really a slide from CMS, if you will, really looking about the maturity level of health plans in value-based, on their value-based journey. We are, of course, Category 4. We have been a value-based organization for 32 years. We started in the delegated model. We have full capitation, global capitation. We incorporate pay for performance to optimize our quality and our cost. And we believe this drives provider accountability and innovation and really great success in our clinical and our member outcomes. I think, obviously with the structure we have, with that level of integration, we're really uniquely positioned to work with our delivery system in creating success in our 7 pillars of excellence. We're continuously innovating and really removing waste and making financial improvements. Coming out of the pandemic, we focused on really righting the organization financially. Tremendous amount of investments across the delivery system, including the health plan, were made to meet the needs of our community. And I'm really proud of the organization. Sharp pulled about $94.8 million out of healthcare costs last year. We are slated to pull another $50 million out in 24. And again, affordability is paramount, and we believe that we have to play a strong role in that. I'd also say technology has played a big role for us. That's the second real big initiative we had last year, was to put in a new infrastructure, a new core admin system for the health plan known as EPIC, which is nationally recognized, if not recognized throughout the world as one of the best core admin systems and electronic medical records that you can use. This is really critically important for us, because if we're going to continue to improve quality, continue to improve service, and take dollars out of the delivery system, the costs of delivering care, we need technology. And so this technology for us is going to allow us to streamline, reduce costs, and perfect the experience, which for us is paramount. We've also embraced wholeheartedly mobile apps, because we know that's what our members need and want, and launched an arguably one of the best mobile experiences through Sharp Health Plan app that was launched in 23. Basically do all your transactions, your health plan transactions online. And in 24, integration will take over as we launch the Sharp delivery system app that's just been launched. And we'll look to integrate that, right? So we'll have single sign-on, so you can do some of your health plan transactions, you can go over and do your provider transactions too. So we're pretty committed to being the most consumer-friendly health system in the universe. Again, a journey really that never ends for us. Let's go to the next slide, if you will. All right, so what are all the investments we're making, all the programs we're doing? How is that expressing itself in our benchmarking? Because if you are a continuous improvement organization, you're constantly benchmarking. So we have been for the last 9 years, the highest member-rated health plan in San Diego. 8 of those 9 years. We were the highest rated in California. A small regional health plan eclipsed us. We plan on getting that back real soon. We are very competitive and enjoy our status as highest rated in many, many categories. We are have the most stars of any Medicare health plan in California at 4.5 stars. This is incredible for us, and really a commitment to what it takes to be successful in our senior community. We also have the highest rating, a perfect 5 stars in Medicare Advantage for coordination of care, customer service, rating of healthcare, and rating of the health plan. And on our commercial population, we have the highest rating in California for coordination of care, customer service, of course, also getting care quickly, and rating of the healthcare and specialists. So a lot of benchmarking for us, and a lot of success in these areas based on the many programs we have. Lastly, I would say affordability is critical for us, and our medical increase over the last 10 years with CalPERS has averaged 2.2%, and we're proud of that. Again, affordability is really important to us. All these results, basically, we've been rewarded with growth. We are, in San Diego, have the largest market share for CalPERS of any product that's offered. And I believe we've been had that market share for, 5 years? And it's one of our benchmarking. And we also enjoy that in covered California as well. And that really speaks to marketplaces like CalPERS, like what you've committed to in terms of allowing regional health plans like ourselves, like WHA, who are in the very fabric of your communities and our communities to compete on quality and service and affordability. And we let our members in our community really vote with their feet, and we count that as a win as we grow. And so I want to thank you very much for your support of regional health plans. And I'll stop there.
Thank you, Ms. Cook.
Questions?
Questions from the committee? Okay, we'll start with Vice Chair Mr. Kevin Palke.
Hey, thank you. Great presentations from both of you. I think I caught a little bit of competition there. A little bit of north-south, maybe.
We've known each other for...
If you could elaborate a little bit more into the tools. I'm a big supporter of sort of the pre-diabetic approach and things that we can do to minimize our members moving into that diabetic range. Can you share how you're utilizing tools, whether it's technology or what is it you're actually using to sort of support these different approaches?
Absolutely. If you allow me, I'll have our Chief Medical Officer answer that question too.
Thanks for that question. And this is something that is throughout the way that we provide care to our members. So the tools are integrated into what we call population health model. So that goes from members that are healthy, for which we have specific programs and services that we benchmark and we have goals for, all the way through to patients at risk, for which pre-diabetics and pre-hypertensives and overweight and smokers, the modifiable risk areas, will be included in. And each one of those has tools, which is part of Follow My Health, which is our member link, and we have a connection and integration with our providers. On our clinical team, our medical directors, our case managers coordinate care daily with our medical groups. That separates us from other health plans that may be using our providers. So the tools are individual for each individual issue. The hypertensive, we have remote monitoring. We have telehealth. We have, it's called the materials of things, which is the ability to have wearables, to have other types of devices that we're able to connect with and real time be able to provide care because we see a problem happening. The best time to be able to identify a problem is before a patient ends up in the emergency room or the hospital and it become a preventable acute care situation. That's how we improve quality, and that's how we reduce total cost of care.
Well, thank you.
Thank you, Ms. Palke. Any more questions for committee? I think Frank Delfino has a question.
It's not working. Oh, am I on?
Not yet.
Okay, perfect.
Hold on. Yes, you are.
Thank you, Mr. Chair. I rise for a quick point of personal privilege. And thank you to both. You guys, obviously, both plans have a secret sauce that I wish could be shared, with many other out there that could use, some of that recipe. That said, I'm from San Diego. I've lived most of my adult life in San Diego, so I'm going to be a little bit, and I've been with Sharp for a long time. So that said, I wanted to thank you, by the way, Ms. Cook, for your incredible leadership that you have had in the community, and especially for your efforts, to lead that efforts to make high-quality healthcare accessible to all San Diegans, and not only to us state workers who are lucky and honored, and privileged to be able to have the plan. And on behalf of all the state workers, by the way, I'm sure you get plenty of complaints from us, but today's the day to say thank you on behalf of all the workers. Thank you for what you do. We truly appreciate that effort. I'm on Follow My Health. I'm still from the rock age. I got the email that I need to transition. I'm gonna try to make that transition. I think in the next couple weeks, or the deadline is. So I hope to succeed, but if not, I know that I can count on your tech people to help me through it. But I want you to know I've been with my health provider, my doctor, for 20 plus years. So no complaints today, but just a message of gratitude. And please continue, and don't forget, that we all need health care, regardless of status, gender, identity, and so on and so forth. Thank you, Mr. Chair.
Thank you, Mr. Rufino.
Thank you so much.
Any other questions to the committee? Okay, I do have a comment and a question. Similarly, we are very appreciative of the high quality ratings you've received from NCQA, and also, like Western Health Advantage, you have very competitive rates, premiums, and so we applaud you for that, and like to continue that effort. And similarly, like Western Health Advantage, you have recently launched a Medicare program, Sharp Direct Advantage Medicare plan, and it's growing. But so tell us how you're going to make it grow. We want it to grow.
Yes, I think I'll turn it over to Michael Bird, who's our Chief Business Development Officer, and really kind of our lead executive on Medicare Advantage.
Well, thank you for that question. It's a fantastic one. And if you look at the kind of growth we've had since we've been added to CalPERS, and we were actually one of the first Medicare Advantage plans when you decided to expand the offering to have other Medicare Advantage plans. We were the first to be offered back in 2019. And if you look at of the available market, we have captured the lion's share of those people who are either aging in or switching. So in 2023, last year was about 50%, very close to 50% of the available market that we were able to capture. So as you know, though, when you've been in a plan for, let's say, 5-6 years, it's most people don't want to switch. So it will take some time to allow that organic growth to happen. But if you look at outside of CalPERS, how we've been able to perform in San Diego, we're now ranked number 4. And as Gary Mizell mentioned, it's a very impacted market in San Diego. There's 16 carriers, and we've moved up the ranks very, very quickly, largely because of our benefit package, affordability, as well as our high quality. So I think the focus for us as a local sales team, and Mr. Rufino, we'll actually help you sign up for the new app if you like. We'll call you right after this meeting. That's part of the Sharp experience. And move to Sacramento. and that's what we're really all about. I think that's what makes us stand out. And so I would expect, just given a little bit of time, that we'll be able to really grow that Medicare membership to a critical mass.
Well, thank you very much.
Mr. Ruvalcaba, I'll just add that we made this decision to add a handful of Medicare Advantage plans a few years ago, as you probably recall, and driving consideration was continuity of care, which I think we all believe in, and not wanting to have members who age out of basic care in a high quality plan have to go somewhere else and potentially find a new provider team and so forth. So we push on both Western Health Advantage and Sharp every day to grow in this space. I think they're taking it very seriously, but we also are aware, to their point, that when we're likely to see most of the growth is when basic members in these plans age into Medicare.
Thank you. And I want to thank both of you for presenting. This was very educational and also more enjoyable than our last health plan spotlight. So thank you very much. I think we want to thank you. And from here, we move on to summary of committee direction.
Yeah, Mr. Chair, I did not record any committee direction.
I did not either, but it's an agenda. I want to make sure. Well, thank you then. And so we'll move into public comment. We have somebody on the phone. So why don't we do that one first?
Yes, Mr. Chair, we have Bruno Galuza.
Please proceed.
Good morning and thank you. I'm speaking to express my deep concern and frustration regarding a recent policy change that has significantly impacted my ability to access necessary medical prescriptions. I've been a member of CalPERS for more than 15 years and have always appreciated the support and services provided, which is why the recent challenges I have faced have been particularly disheartening. A few weeks ago, I was informed by my pharmacist that CalPERS no longer allows for the filling of 90-day prescriptions in person, instead requiring mail-order prescriptions for this duration. This change has caused significant inconvenience and stress for me as it restricts my access to essential medications prescribed by my doctor. I immediately began reaching out to CalPERS to see clarification and request a reversal of this policy change. But unfortunately, my efforts have been met with numerous obstacles and unfulfilled promises. Over the past week and a half, I have made multiple attempts to contact CalPERS, only to encounter rude and unhelpful responses. I was initially assured by a senior staff member that the policy would be reverted back to its previous state, only to be transferred to OptumRx, where I was given false information about updating my prescription access. Despite following their instructions and waiting for hours, there was no change, indicating a lack of integrity and transparency in the communication process. The decision to limit prescription access to mail order not only inconvenienced members like myself, but it also raises serious concerns about the safety and reliability of receiving medications via mail. In my neighborhood, mailbox theft is a common occurrence, and relying on mail order prescription puts my health at risk due to potential delays or theft of medication. I urge the Board of Administration to reconsider this policy change and restore the option for members to obtain 90-day prescription in person as it was before. This change not only disregards the practical challenges faced by members, but also demonstrates a lack of empathy and understanding for the real-world implication of such decisions. I trust that the board will take swift and decisive action to address this issue and restore the previous prescription policy for the health benefit of all members. Thank you for your attention in this matter.
Thank you for your for your public comments, sir. We have received other complaints, other concerns about our new mail order preference program. And I think part of the problem was the member communication, and we are working on some resolutions. So somebody will get back to you. Don, did you want to add something?
Yeah, I just wanted to say to the caller that, you know, obviously we're going to look into, one, we will reach out to him directly and happy to talk through more of this. And obviously we'll follow up. We never want to hear stories like that about our experiences. The fact that we don't encounter them very often I think it speaks to the the high quality and the commitment to provide excellent customer service. So we will look into that one as well. We made the board made this decision as a savings opportunity. We are projected to save several $1 million by transitioning to mail order on 90-day fills. Members are still able to fill 30-day prescriptions, so it involves more visits to the pharmacy, but at the pharmacy level. And we're committed, if there are special circumstances with any particular member, we're committed to working through and figuring out what we need to do to make sure that that person has appropriate access to their medication in any fill size. So we'll work through that. Again, our apologies for the experience, and I just wanted to add that.
Thank you for that explanation, and thank you again for calling. Our next speaker is Margarita Brown, please.
Thank you, Mr. Chair. I apparently talked at the wrong time about long-term care, so I'm back. Under the terms of the wedding and CalPERS lawsuit settlement, CalPERS is prevented from increasing premiums on long-term care policies until November of this year. I have been advised that this month is the first time the committee may consider increases, yet the only item on the agenda for long-term care is a closed session item. If rate increases for the long-term care program have not been discussed yet because they're not anticipated, great. But if increases are already under consideration, when will this committee publicly provide CalPERS members the relevant information on the important questions? As you may know, during the wedding lawsuit settlement, the court found that CalPERS intentionally targeted premium increases on older policyholders with inflation protection policies, inducing these older policyholders to abandon their policies while never receiving benefits. During the settlement hearing, Judge William Heiberger described a CalPERS policy as follows: CalPERS engaged in an abrupt rate increases for people with inflation protection and lifetime benefits to the very purpose of driving them off and getting the risk off the books, which is something other than across-the-board rate increase. In particular, the rate increases at that time were in the nature of 85% and did not include rate increases for enrollees who did not buy inflation protection or lifetime benefits. So you can imagine these policyholders, which include me, are very interested in ensuring that we are not the target for extra premium increases the next time. CalPERS owes it to us to provide upfront information about whether increases are needed, how much it needs to recover, how much of the increases are driven specifically by inflation, as that amount should not be charged to those of us with inflation protection policies, and details on how the increases will be distributed across categories of policyholders and why. Thank you.
Thank you. Do we have any more public comment? Thank you. So we will adjourn the meeting of the Pension and Health Benefits Committee, and we'll break for lunch. Thank you.
First order of business is roll call.
Teresa Taylor.
Here.
David Miller.
Here.
Deborah Gallegos. Here. Frank Ruffino.
He's here somewhere.
Nicole Griffith for Reina Ortega. Ramon Rubalcaba.
Here.
Yvonne Walker.
Excused, I'm sorry. All right, so next order of business is the election of the chair and the vice chair. For that, I am going to hand the gavel over to Mr. Miller. And hold on, David. All right.
Okay, I have the gavel. I will now take nominations for chair of the Board Governance Committee.
I nominate Teresa Taylor as chair.
Okay, nomination is made. Are there any other nominations? Are there any other nominations? Are there any other nominations? All right, I have a motion to approve Teresa Taylor as chair, and let's have a roll call vote.
Is it roll call?
What?
You can just ask.
Okay, we're all here. Okay, all in favor, say aye. Raise your hand.
Aye.
Aye. Any opposed? Any abstentions? Okay, the motion passes. Congratulations, President Taylor. I will.
Thank you. Give it back.
the
Thank
gavel.
you. All right. So with that, I will move on to the nomination for vice chair of the Board Governance Committee. And with that, I nominate David Miller. So are there any more nominations? Are there any more nominations? And are there any more nominations? Hearing none, with that, all those in favor of David Miller for vice chair, aye?
Aye.
Okay, any opposed or abstentions? Thank you. Congratulations, Mr. Miller.
Thank you all.
We didn't have to change seats or anything. That's not the only reason. Just kidding. We are on executive report. Mr. Jacobs.
Yes, good afternoon, President Taylor, board members. I think you've done the heavy lifting for the afternoon by voting to elect the president and the vice chair as your chair and vice chair. And then really most of the board governance related issues will be taken up tomorrow in front of the board in connection with the self-evaluation item. The only thing left for this agenda would be the approval of the consent items. And with that, I will stop talking.
Okay. Well then, yeah, this is a simple meeting. So we're moving on to number 4, action consent.
Move approval.
Moved by Mr. Miller.
Second.
Seconded by Mr. Ruffino. And Frank is here, by the way. All those in favor?
Aye.
All those opposed? Any abstentions? So the action consent items pass. I did not hear anything come off information consent items. So with that, we adjourn the meeting, I guess. Is that where we're at?
I think so, unless there's public comment.
I don't have any public comment. Wow.
Okay. New record.
Well, as you know, tomorrow you're doing your self-assessment, and typically if there are any follow-up actions on that assessment, they are done through governance. So
yes.
Likely future agenda items.
Yeah, we will have more agendas later. So this meeting is adjourned. Well, I will see everybody tomorrow morning at 9 a.m.